Hey, Baldy, it's Dr. Burns. We're just getting started inside your knee. We've inserted the scope right in the middle of the knee. There's normal, good, smooth cartilage there. All that white. That's very, very good. That's the end of your femur there. Your anterior cruciate ligament of your ACL is right there, attaching the tibia below to the femur up above. Now, if we look over to the right, there is your meniscus tear. That chunk of tissue that you can see spit out the front there is a tear in that medial meniscus. As a way of comparison, we'll look over to the lateral side of the left side of inside of your knee. We'll put the knee in a little bit of valve into this area. This is your lateral compartment. We'll take a picture of that. And there's your lateral meniscus, that sort of C-shaped soft structure that floats in the breeze right there, in between the femur above and the tibia below. Again, perfect looking knee on the lateral side. But when this meniscus gets torn and flipped forward, it forms what we call a bucket handle tear, which is what you have on the other side. So we're going to go back and address that medial side now. You see the difference there? There's your medial meniscus there being spit out at us. So we're going to establish another portal and we're going to see how repairable this is. It's not looking repairable as of right now. Alright, Baldy, so now we'll insert this little needle so that we can manipulate your meniscus back into position where it should be, back over here. That's where it should be. Doesn't really want to go because it's been spit out the front for so long. There. A bit better. Alright, Baldy, so we've got this reduced, we've got our other cannula in, and this is what we call a white tear, which means that there's no red in the area. Red means blood supply. This tear here is not going to heal. It's got no blood supply, but the good news is that maybe all this meniscus that's left over here may be good enough for you to survive. I'm not sure, but maybe. So what we're going to have to do is we're going to have to remove this little band of tissue here, and we'll see what we're left with in a minute. So working over here in the corner. Good. And now we're going to go about detaching that. Now, Baldy, we've switched the scope to the front medial portal so that we can just take what needs to be taken, staying right on your intact meniscus that's behind us, right there. Looks very good so far. All right, now, grasper. Grab the tip of this. Carefully. We'll take a picture of that. And we'll pull it on out. Don't mind getting a little bit better grasp on it though.
Okay, let me call you back.
A bit better grasp. Let's see if we can't pull it through our cannula. That. Now we're just going to pull this right on out of your knee. There we go. Beautiful. All right, Baldy, the last thing we're going to do is you're just going to smooth out what you have left of your meniscus. You've actually still maintained a huge amount of your meniscus. It almost looks like a normal meniscus. You just sheared off part of the top of it. Now, the rest of this meniscus isn't as strong as your normal meniscus, so you're certainly at risk to tear this again in the future. But you also have maintained the vast majority of your meniscus ability to be a cushion. And that's really, really good. And we'll also be able to get your motion back very quickly as well, as long as we push it and as long as you work hard on it. Your knee, by the way, did get to full extension when you went to sleep. Now that we've got that piece of displaced meniscus out of the way, I think it's going to bounce back to normal motion very quickly. Now what we need to do is just remove all these other little bits of meniscus here that are so unstable that they're going to get ground up the minute that you twist or walk on this, and leave behind everything that we think might heal. And if we're wrong and if it doesn't heal, then so be it. We'll come back and take it out later. But what we don't want to do is just go ahead and remove too much meniscus on you and remove all of the cushioning that you have in here and increase your risks of getting arthritis in the future. So there's short-term goals and long-term goals. Our long-term goals are to maintain as pristine a joint surface as we can without getting an arthritis. Short-term goals is obviously to make the pain go away and the motion come back, and I think that we'll have done that. All right, Goldie, so we're done. I'm very happy with the amount of meniscus you have left. Hopefully that will not, as a weak point, continue to tear on you. It should not, but if it does, then we'll go take out some more. The meniscus tear that you had was a no-brainer. That would never have healed without any blood supply, so this is the right thing to do. But I'm happy with what you have left. You don't have any signs of arthritis, which is good, and you still have a lot of your meniscus left here. At least 80% of it, I would guess. So that's a good sign. So you can walk on this, you can use it. I want you working on getting all your range of motion back. You can extend it and get it as straight as you possibly can. And put some ice on it, get the swelling down, and call me if you have any problems. Good luck. Goldie, one more thing. This is the epilogue to your surgery. This is the little worm or the little piece of meniscus that we removed. You can see it's about 3 centimeters long and it's fairly thin, and that's sort of the upper leaf that we had to remove, partial thickness of your meniscus. So that's what it looks like outside the body.